thank you for coming tonight. My name's James Maskill. I've been practicing now on my own for a couple of years. I'm in St. Joe at the COPS building, do surgery in Watervliet. I'm currently moving offices. It's on Niles Road, not Avenue, the 2500, so it's right between the COPS building and the hospital. And that's in about a month, so mid-July, or early July actually, I'll be there. So we're excited about that. But a little bit about myself. I have 4 other siblings, 3 older brothers, a younger sister. 2 of my older brothers actually do foot and ankle as well. One's a podiatrist, one's an orthopedic surgeon. Something unique about my brother and I, who are podiatrists, is we've had a foot and ankle fellowship orthopedic training for 1 year that we did out in Maine. So the same guy actually trained all 3 brothers, and kind of interesting but fun. I got another brother who does orthopedic sales, and then my sister is in EMR, so sets physicians up with electronic medical records. My mom is a retired dental hygienist, and my dad is having a retirement party tonight up in Grand Rapids. He's been with Spectrum for some time now, and he's about done, so he's excited about that. But that's a little bit about me. What I should add, training. I went to Chicago for med school. Went to San Francisco, did 3 years of podiatric foot and ankle training, and then I went out to Portland, Maine to get the orthopedic foot and ankle fellowship training for a year. So I've kind of made my trips around the United States. But we're just going to talk about common foot and ankle issues, stuff that I see every single day in clinic that hopefully can hit home to some of you who are here tonight. So the whole point is just getting back on your feet. Foot and ankle, what some people don't realize is when you actually, with just walking alone, there's 3 times body weight of force that goes through your foot. If you run, it's 5 times body weight of force. So it's different than upper extremity where you don't use it. When you're on your feet and they hurt, they usually hurt, and it can be debilitating. So the most common thing that we see, that I see, is plantar fasciitis, and the second most thing that has to do with heel pain that I see is called a Haglund's deformity, or it's really what it is insertional Achilles tendonitis. 2 different areas of the heel. Both are related to the same problem. I'll see that 5 times in a clinic day easy. So it's very, very common. So breaking down what plantar fasciitis is, since that's the most common thing that I see. Plantar is the bottom of the foot. So it's heel pain that's on the bottom. Fascia is a ligament, and itis is inflammation. So put it all together, plantar fasciitis. Symptoms is pain when you usually get out of bed with the first couple steps or 10 minutes in the morning. Sometimes people can barely walk. Then after a period of time, it just kind of gets a little bit better. May not completely go away, but usually gets better with walking on it some. It's usually described as sharp or stabbing pain, but people will say it's burning, it's a dull ache. I mean, it can be anything, really. And often subsides, like I said, after 15, 30 minutes, or lessens to a certain degree, and I'll tell you kind of why that happens. So you have to say, well, what causes the heel pain? So what, why, and what do you do about it. So a lot of times people think it's a spur. So this is a big spur on the bottom of the heel that a lot of times about 90% of the people come in and say, my heel hurts, I have a big spur, I had, the primary care took an x-ray, and my heel spur is killing me. Well, it's actually not the spur that hurts. What hurts is the tearing of the plantar fascia. So in this picture really does a good job of showing you what happens. And I'll show you kind of the biomechanics in a minute. Back to the Achilles tendon, a lot of times people complain of a spur on the back of the heel. So there's pain on the bottom of the heel, pain on the back of the heel. The pain on the back of the heel, right here where people develop spurs, that spur actually hurts. And that's for kind of a different reason. But same thing, it hurts because you have basically tearing of the Achilles tendon, not the plantar fascia, right where it inserts. So then why does the plantar fascia or Achilles tendon tear? Well, the main reason is because your Achilles tendon's too tight. So what I always say is the heel pain is only a symptom. It's not the real problem. The underlying problem is how tight the Achilles tendon is. And it's specifically the muscles that make up the tendon, which I'll point out here in a minute. Those muscles, in about 80%, 90% of the time, it's one of the muscles that are tight that cause all this heel pain. So the heel pain's the symptom, it's not really the problem. So then you have to address the problem. So I don't know if you guys can see this or not, but I'll use this in a minute. What happens is when your Achilles tendon gets so, oops, oh boy. When your Achilles tendon gets so tight, basically, why does that happen? Well, it happens usually at night. You sleep with your foot not at 90 degrees, but it's under the bed sheets, and it's like this. The way you sit in a chair, it's usually down. If you're driving a car, sitting at the restaurant, whatever, it's usually down. Then you go get back up after periods of inactivity, and your heel's hurting you. Then you walk around for a little bit, gets better, you go sit down, have dinner, same thing happens. So what's happening during those periods of rest is your Achilles tendon gets tight. So when your Achilles tendon gets tight, think of the plantar fascia like that ligament that you saw up there on the bottom. Think of that as a rubber band. Your Achilles tendon comes right behind your ankle and inserts right here. So when after periods of rest, your Achilles gets so tight that when you go step down, your Achilles is so tight that it actually pulls up on your heel like this, and the ligament on the bottom tears. Then you walk around 5, 10, 15, 30 minutes. The walking alone stretches out the Achilles and the muscles just a little bit to take tension off here. So if this isn't the weak point, then if you have a spur on the back, then it yanks on the spur. So you get a spur outside of a joint for one of two reasons, either tension or pressure. So in this case, it's tension. Imagine all the tension that's yanking up on the heel bone, your body responds by saying, okay, well, I'm going to grow a spur. Problem is it grows a spur up the Achilles tendon, and that's why that spur actually hurts, because it's the Achilles tendon that's tight, yanking on that spur. A lot of times people just have pain directly on the back of your heel. So what do we do about it? So the biggest thing is you have to address the problem. So the problem is the tight Achilles tendon, so you have to stretch it. And the Achilles tendon's the biggest tendon, strongest tendon in your body, so it takes a long time to stretch out. You usually have to do your stretches 3 to 4 times a day and be faithful with it. The good news is about 80-85% of the people can stretch out their Achilles tendon enough to get rid of their heel pain. There's a subset that can't. Of those that can't, you can do different modalities. You can try physical therapy. Sometimes orthotics help. Cortisone injections. One thing about that, there's a little asterisk on the slides here, is I will never inject an Achilles tendon with cortisone or any tendon because I've seen too many ruptures from that. So it can weaken the tendon, especially if the tendon is somewhat diseased. You basically weaken it, they go do something step funny, pop, and then they're back in the office with a ruptured Achilles, and then you have to fix that. So that's one thing I don't do. Physical therapy is probably your best bet for the pain on the back of the heel, not necessarily the bottom. But I do both. So physical therapy is a great modality. We use it all the time. And I'll go pretty much to every length conservatively to treat the patient without surgery. But at the same time, I don't keep them in pain for a year because the surgical treatments for this are pretty good. The success rate, especially with plantar fasciitis, from a surgical standpoint, I do a small operation where I make a 3-centimeter incision on the inside of the calf, and you basically lengthen the calf. It's like a 10-minute operation. Outpatient surgery, you wake up in a boot, you can walk that day. You live in the boot for 2 weeks, come back, get the sutures out, and then stretch to maintain the length that was achieved in surgery. So that's got about a 93-94% success rate of getting rid of your heel pain, which is pretty good. But again, most people can do it on their own. The surgical treatment for the spur on the back of the heel is a little bit different because that spur is actually growing in the tendon and the Achilles tendon is diseased. So a lot of times what I have to do is from a surgical standpoint, so if they fail physical therapy is that's the best one for that. You do an operation where you lay the patient actually on their stomach during surgery, and you go right through the tendon. You lap the tendon this way, make a window this way, so you're staring right at the spur. And you take all the spurs down, clean up the tendon, and then you tack the tendon back down onto the heel bone with anchors. That success is very good. I do probably one of those a week, believe it or not. That one's a little different, though. You're non-weight bearing for 5 weeks, and then you go into a walking boot, usually for 3 or 4 weeks. So it's a little bit more involved, but again, the outcomes of that are pretty good. Postoperative pains, for whatever reason, very minimal. Patients do very well with that. So here's just the list of conservative treatment options. Again, you have to stretch the Achilles tendon. That's the real problem. Physical therapy is good for both spurs on the bottom and the back of the heel. Orthotics, that is selective. It's usually people who have plantar fasciitis with flat feet. High-arched feet with plantar fasciitis, I usually don't do orthotics because you put them in an orthotic and it actually stretches the plantar fascia, and I've found over time and trial and error that actually hurts the patient and they don't like it, so I don't do that anymore. And then cortisone injection, again, only in the plantar fascia. And a lot of times I do that after surgery because where I lengthen the calf, because the problem is then fixed. And if they have any residual pain, then you give them a cortisone injection, and it nips the inflammation, in the butt once and for all. And patients usually do better with an injection after surgery than before. And with that said, I still do injections before surgery, but most of the patients then feel good, and then they don't stretch, and then they come back 4 months later and their pain's worse because they went that whole time without treating the real problem of why they have it. So just real quick, what I do for the plantar fasciitis, the smaller surgery where you can walk that day, is this is the muscle group called the gastrocnemius muscle. That muscle gives off this white tendinous band. It's called an aponeurosis. And that is what I lengthen right there. I actually cut that, and the muscle then goes up just a little bit, but it's enough to lengthen the Achilles tendon or that muscle to take tension off of the bottom of the foot. So that's the muscle. When you flex your calf, you can actually see it and feel it. That's that muscle. That's the muscle that's usually the culprit about 80-90% of the time. And I do an exam in the office that lets me know what muscle's actually tight. It's just a simple 5-second clinical exam. And then for the surgical treatment of the spur in the back of the heel with the Achilles tendon is cleaning up the tendon, taking the spurs off. So that's heel pain. That's what I see that most often, and those are the common things that I do for it. Again, I don't leave the patient sitting for a year with heel pain and try 10,000 different things, because by that time, if something doesn't work usually in 2 to 3 months and they are no better, then that's when I'll do something surgical. If they're getting better at the 2-month mark, which is typically when I see them back, then I say keep doing it, because it takes about 4 to 6 weeks for them to even start to notice a difference. So if they say, yeah, I'm doing a little bit better, I think, and then I say keep going with it, because they usually just get better. So let's just talk about some other common things that I see. Arthritis, see it every day. Same with tendinitis. Trauma, I like to do trauma, any ankle fractures, heel fractures, any fractures of the foot. That's interesting to me. I enjoy doing that. Flat feet, high arched feet, bunions, hammer toes. That's kind of the run of the mill, and we'll just kind of go through some of those in what we offer for that. So arthritis, basically, how I explain it to patients is arthro is joint, itis is inflammation, so basically you get inflammation of a joint. What happens is, if you can see on the left, that is an arthritic joint. This is bone on bone. This is a normal joint. So this black space there, that's the joint. That space is actually cartilage. So every joint has got bone with a carpet of cartilage on it, bone with a carpet of cartilage on it, and it moves together like smooth ice against smooth ice, almost frictionless. When you get arthritis, how I describe it, it's like bone with sandpaper on it, bone with sandpaper, and it's like grinds and it hurts the patient. That's how I describe arthritis. Symptoms, startup pain, just to get up in the morning or after periods of rest, hurts, and then you get going a little bit, feels a little bit better. Still may have pain, but kind of feels better. Pain with motion, that's either walking. A lot of times, certain joints on uneven ground really hurt patients if they're arthritic. It can flare up with vigorous activity. You can even do that with walking. Gets red, hot, swollen. People think they have cellulitis, but it's just inflamed joint. And then just all the above, just difficulty walking. And that can be any joint in the foot. It can affect you. What are treatments for arthritis? Orthotics, I do all the time. I think they work very well, especially if you get one that's made well. Ankle bracing, if there is a ankle arthritis. And a lot of times I do both. Patient comes in with an arthritic ankle and a flat foot. You give them an orthotic to support the flat foot and an ankle brace to just make sure all the forces are going across the foot and ankle as they should. Cortisone injections, that's selective. You can't really put cortisone injection into this joint unless you've got fluoroscopy, which is X-ray, which is the joint's just so tiny. You can do it in the big joints, in the ankle and the hind foot, sometimes the big toe joint. I don't do that often, but occasionally. You can immobilize people in casts or boots. Don't love doing that. Joints need to actually move to stay healthy. If you lock them up, it can actually make them worse, but that's an option. And then shoe gear modification sometimes helps. As simple as buying a little bit bigger shoe, toe box, skipping a lace here and there. You know, if you've got pain on the top of your foot here, sometimes helps just to get you by. So what are treatments? Well, it's kind of, if you look there, you see fusion, 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 fusion. That's the main thing you do for arthritis in the foot. The ankle's different. There's a couple ones that are different. The ankle, you can do a total ankle replacement or an ankle fusion. Both are great operations. Sometimes you can't always do a total ankle replacement in everyone. There's certain parameters you have to kind of meet. For me, I'm pretty conservative with that because I like them to last a long time and not need a revision 2, 3, 4 years later, because you start running out of bone when you're doing total ankle replacements. Ankle fusions and also, that's probably the gold standard still. Do those frequently. You wouldn't even be able to tell someone in the room if they had their ankle fused. They usually don't walk with a limp. They actually walk better afterwards because their pain's gone. So they gain functional mobility. The hind foot, what that is there's three joints under the ankle that provide the in and out motion. So those people walking on a side of a hill or on a little slant or curve that have pain may have some arthritis of those joints that provide the in and out motion. Those, if they become arthritic, you fuse them. If that's the case, if they've failed all the conservative treatment. That's obviously surgery is the last thing that you do. You can do that for flat feet or high arched feet. Midfoot arthritis, that's right across the top. A lot of times people hurt with shoelaces that go across the top. If you're going to pick a spot to fuse in your foot, that'd be the one, because those are actually non-essential joints. They help provide an arch. So if you look at under the foot, it's like an arch. So it's very, very stable, and those joints really don't move that much to begin with, but when they become arthritic, it is sore. And you get spurs and everything else that hurt. So that fusion does very well. And then forefoot arthritis, and it's usually the big toe joint. I forgot to put one up there, one that I actually do frequently, but when you get arthritis of your big toe joint, you usually get spurs on the top, and the toe doesn't really move that well. Again, if you fail the conservative treatment, which is usually an orthotic, which actually worked very well, the next step would be a surgical procedure, and you can do one of three. Take the spurs off. Regardless of how arthritic the joint is, you can still take the spurs off, get a little motion, and I tell the patient, you know, if it hurts and we don't get you better, the next option is to fuse it. And for even the worst looking joint, you take the spurs off, you give them a little bit mobility, and they love you, regardless of how arthritic it is. Some don't, but traditionally, what I've found is they actually do very well. Your other option is you can put a big toe replacement in there. There's about 30 of them on the market. In my opinion, I don't think that many of them have a good track record of working long term. I don't really put them in, but I've taken some out. And you have to then, becomes a salvage procedure where you have to kind of put a piece of cadaver bone right in the middle and try to fuse the two bones together. So I usually just go with either taking the spurs off or fusing the big toe joint. And you put it in a position of function where they can walk without a limp. The only thing they really can't do is wear a high heel or, you know, garden and sit with their toes like this. So that's kind of the arthritis of the foot and ankle and what we do. At the end of the day, it's usually some sort of a fusion, unless it's the ankle or the big toe joint. Here's a picture of a total ankle replacement, which are getting, the technology they have now is just getting better and better. It's probably not as good as a hip or knee quite yet, but they're making daily advancements in that. Really what you do is you cut out the joint and you put an implant in. And now you can take a CT scan of the joint. They make the components and cuts for you out of the patient's CT scan to get the corrections, and it's pretty cool. And it makes the guessing game a lot less when you've got a template that's already made for you based on the patient's ankle and their CT scan. So that's pretty neat. It looks a bit barbaric, but that's ankle fusion. Pretty much either a combination of plates and screws. But to be honest, the patient, if that's their ankle, they have no pain and probably walk without a limp, and you'd never know it. You could probably run a short distance if you had to, but it's nothing you're probably going to run a marathon with. As far as flat feet, we'll get into a little bit of the flat feet, high arched feet, and bunions and stuff. I get every single day the high arched foot or the flat foot, and the patient says, we have a little thing on our Epic system or EMR where it says ankle pain. So I'm like, well, I bet you they have a flat foot, or vice versa. So they say, I have pain on the inside of my ankle. Well, it's perceived ankle pain. It's actually their flat foot that's causing it. What's causing the pain is, for flat feet, it's caused by the posterior tibial tendon. It's a tendon that literally courses right around the ankle. That's the tendon. Its job is to hold your arch up. So when it becomes insufficient, or you've had a flat foot for so long, the tendon gets small tears, and it's notoriously a bad healer. So studies show, if you look at it under a microscope, it doesn't heal with good tendon anymore. It heals with fibrous tissue, scar, and a whole bunch of crud, and it becomes thick, sore, and swollen. And it doesn't work that well. So then the foot becomes more flat, and you get pain in other places, and that's the pain on the inside of the ankle that I see most. What can you do? Well, stretch the Achilles tendon, orthotics, sometimes physical therapy. It doesn't always work that well. because once that tendon gets diseased, it's usually diseased and it's just a nidus and it hurts. The Achilles tendon is so powerful that what happens is what we've learned, I guess, now is that it inserts on the back of the heel right here. When people have a flat foot, their heel is off to the side. So you can see here, his heel does not line up with the back of his leg. It's off to the side, it's off to the side. You can see the Achilles coming down. It wants to insert about here, but it comes down and bows that way. So when the Achilles tendon is off to the side and it's tight, it pulls you over more, causing more stress on the inside of the ankle, and it's just a vicious cycle of your Achilles becomes more flat or more tight, your foot becomes more flat, the tendon gives out, and then it can go from stage 1, 2, 3, which is just a tendonitis, stage 1. Stage 2 is a tendonitis with a flat foot, but it's not an arthritic flat foot. Surgical procedures and treatment options are completely different, where if you've got a supple foot that actually moves without arthritis that's flat, you can do surgical procedures that reconstruct the foot without touching a joint. If you get to stage 3 and your foot is flat and stuck, meaning you can't walk on uneven ground that well, you've lost your in and out motion, then your conservative treatment options have dwindled to probably stretching and orthotics, and the surgical options to fuse the hind foot. And when you fuse it, you correct the deformity through the fusion. And that would be the flat foot reconstruction. So that's just vague because there's so many different procedures you can do to actually correct the flat foot. High arched feet is as common as a flat foot, but it's completely opposite. So the orthotic is 100% different. The Achilles tendon and stretching is the exact same. You can see here how the heel's now on the inside. The Achilles tendon's coming down and coming down to the inside. So the Achilles tendon's also a problem here. So this is a patient coming and saying, I've got pain on the outside of my ankle, it's killing me, and it's often tendonitis or weak ankle ligaments. This patient is prone to ankle sprains or just walking, stepping on a pebble, and their ankle goes, rolls. That's that patient. And how you tell really the difference as far as what's going on and diagnosing is actually getting the patient up, standing them up, looking at what their feet look like. Then you have to say, well, where do you hurt? And they point with one finger, one spot, and you can pretty much diagnose what's going on, almost 95% certainty without any MRI, CT scan, what's going on. A lot of times you still need those things to help guide you where to go surgically and what to do, but actually physically touching the foot and the ankle and figuring out what's going on is paramount. That's how you get the right diagnosis and treat the patient correctly. So the treatment, it's the exact same as flat feet. The orthotics are 100% different. So there's 1 or 2 over-the-counter orthotics for high-arched feet. Can't find it. You won't be able to find them in any store. You have to get them online. So a lot of people still really don't understand the difference and why someone would give you the same orthotic for a flat foot as those who have high-arched feet. To me, makes no sense. So in high-arched feet, if you give someone arch support, you're actually splinting them in their deformity. So most of the time it makes them worse at the end of the day. They go walk, sprain, because they can't come in and offload the outside of their foot. So we do orthotics all the time. Bunions and hammer toes. You see this every day as well. Very common. Unfortunately, there's not a whole lot you can do for conservative treatment for these because it becomes an issue of how do you fit your foot into the shoe. You can try padding, bunion splints, corn pads for on top of the hammer toes, things like that, or a bigger shoe with a wider toe box and more room in the shoe is usually the conservative treatment. Sometimes you can get orthotics. I give the patient the option. It doesn't take away the bunion. It may help slow the progression of the development of the bunion where the bunion comes from. There's multiple etiologies, but in a male, it's usually because they have instability of the joint behind their bunion back here in their midfoot. Almost every male that I see with a bunion has that. This is the bunion, by the way. And a lot of times you take an x-ray, and there's no spur, there's nothing. It's just the bone is like this. So the metatarsal, which is this bone, drifts that way. And to counteract the force, the big toe goes the opposite way. Goes that way. So really, they don't have a huge bump on x-ray. It's just the bones aren't lined up right. So most of the time, the problem is back here. The surgical fix for that, there's 100 different ways to fix a bunion. I do a few because I think one works pretty well. It's more of the industrial strength version where the recurrence rate is very, very low. They can still come back, but it's usually below 5% of coming back. So I fix a bunion based on why is the bunion there? Is it there because of instability of a joint back here? If it is, I'm going to fuse that joint and correct the bunion up here. If it's just because some people are kind of born with a little bit of what we call hallux valgus, or their big toes going this way, and they're relatively stable, then I'll do a simple osteotomy down by the head of the metatarsal and correct it that way. So nothing's cookie cutter. Hammer toes, usually, if you fail conservative treatment, I do just a small operation where you basically cut out the joint where the toe is hammered, like that. Cut out the joint and then pin it. Does fairly well. You get a stiff toe, sometimes a swollen toe, but the one thing that I tell every single patient is I don't do the surgery for cosmetics. It's that I do it for pain relief. So if your toes aren't perfectly straight at the end of the day, or one kind of drifts off, one way or the other, but you don't have pain, or you're 90% better, to me that's a win. So I don't do cosmetic foot surgery. And that's a hammer toe. There's nothing really, it's pretty cut and dry. You either live with it or try some padding or get it straightened out. The other thing I'll do hammer toe surgery for that I see actually often, and sometimes are diabetics, where they get sores on the top of their toes. So I will be more apt to pull the trigger and say, you know what, I want to straighten that toe so you don't get an ulcer, so it doesn't get infected, and we have to amputate the toe. So sometimes I'll do that. I even do that for big flat feet or flat foot and high arched reconstructions in patients with diabetes who ulcerate and then they heal and then they walk again and then they ulcerate again and they heal and they ulcerate again. So I'll correct their foot, alleviate the pressure so they don't ulcerate, so they can keep their foot. We do that often as well. So in a nutshell, basically my goal is to keep patients moving, get them back to their prior activity, or at least back to what they want to do. For me, from a surgical standpoint, I always sit down patient face to face and I just say, what do you like to do? For me, it's going out playing with my kids. I like to wakeboard, fish, do those things, walk in the woods. If I can't do those and I've failed conservative treatment and I just say, you know what, I'm going to stay home and not do the things that I like to do, that's time to do something surgical for me. If you can still do all those things and you've got a little pain here and there, maybe surgery's not the best thing for you because I have to make you better. So that's usually what I say is when the patient can't do what they want to do and they've failed conservative treatment, it's surgery. The foot and ankle can be debilitating. Like I said, the amount of force that goes through every step, it hurts. And it can sometimes be life-changing, but it also can be life-changing if you can get rid of that pain. So my goal is just to keep people moving. And, every single month, a new company comes out with just new innovative ways of making things better, better hardware, better way to fix something, better conservative treatment options with physical therapy, orthotics, all those things, which is awesome because it's great tools for us to get patients better. That's it. Questions?